Hello and welcome to Clinical Exam Series with Dr. Piro. Today we are going to be looking at clacking of cough. When you are clacking cough, there are three things I want you to note in real life and in the exam. Number one, use lay terms while interacting with your patient, since patients and diseases don't read textbook. Number two, in the exams, use semi-open-ended questions or closed-ended questions, such as do you have cough, instead of open-ended questions such as how do you feel. And lastly, do not load, even though in the course of this video I've asked questions as groups, in the exams do not load questions on your patients or the simulator. Now when you're clacking cough, these are the questions you should ask. How did it start? When did it start? Has it progressed? Has it reduced, or it has stayed the same? You want to also ask, what is the character of the cough? Is it Bachy? Bachy cough will point towards pertussis as a likely etiology. You want to also ask if the cough is productive of sputum. If it is productive of sputum, what is the color of the sputum? What is the volume of the sputum? Is the sputum foul smelling? Or is it non-productive? When the cough is non-productive, likely causes would include patients on drugs such as ACEIs, example, captopril. Disseminated thromboembolism to the lung, pulmonary thromboembolism, is also a possible cause of dry cough. If it is productive of sputum, what is the color of the sputum? Now, when the sputum is yellowish, it points towards a bacterial origin, so it's likely a bacterial pneumonia. When the sputum is black, aspergilloma is a common cause of black sputum. When the sputum is greenish, Pseudomonas aeruginosa is a common cause of green stained sputum. When the sputum is pinkish, it points towards patients who have pulmonary edema. Frothy sputum, on the other side, points towards patients who have heart failure as a possible cause of the cough. Also, we want to know if the sputum is blood stained. Blood stained sputum can point towards tuberculosis or patients with cancer. Now, we want to also ask if the cough varies according to the times of the day. We know that cough of asthma is worse at night, while cough from COPD is worse during the day. We want to also ask if the cough is dependent on position. If a patient has difficulty lying flat on their back and coughs up when the patient sleeps lying on their back, the patient is said to have paroxysmal nocturnal dyspnea. When patients prefer to sleep on one side rather than the other side, or coughs when sleeping on the opposite side, the patient is said to have trepopnea. Trepopnea is usually caused from fibrosis or an obstruction of one of the main bronchi. The patient prefers to lie on the unaffected side because when lying on the unaffected side, blood pulls down by gravity and that improves perfusion. Now, these questions we've asked are to characterize the cough when we're following the 5 C's: the complaint, the character of the complaint. Now we know the complaint, which is cough. We know the character of the complaint, which we have characterized by asking these other questions. Now, in knowing the cause, the CAUSE of the cough, we need to ask for associations. And a very helpful mnemonic that I used to remember, the association when it comes to cough is foreign coach, F coach. F will be foreign body aspiration. In foreign body aspiration, the cough is usually sudden in onset, and this is common in unconscious patients, children, and elderly patients. So we want to know if the cough is sudden in onset. Secondly, C, we want to know if the cough is due to cancer. So is the patient a smoker? Does the patient consume alcoholic beverage? Is there history of what we call the triple A of cancer: anorexia, anemia, and asthenia? So if there weight loss, is there loss of appetite, and is the patient having symptoms of anemia such as lightheadedness, fainting spells, dizziness? We want to know if what is the occupation of the patient? Is this cough due to an occupational lung disease such as asbestosis, silicosis, bagasosis, exposure to cotton? Is it due to siderosis, exposure to iron? So occupational lung diseases can also be a cause of the cough. Now, A, asthma is also a common cause of cough. So we want to know if there's no history of noisy breathing, family history of asthma and atopy. We want to also know if there is history of chest chest tightness, and history of triggers causing cough, such as dust, pollen grains, or smoke, or insecticide, or perfumes. So this is a possible pointer towards asthma. Now, T, tuberculosis. Is there history of weight loss, drenching night sweat, hemoptysis? This will point towards TB. Is there also history, since TB and low grade fever? Since TB also coexists with HIV/AIDS, you want to know if there's history of multiple sexual partner, history of unprotected sexual intercourse, history of blood transfusion, and want to also rule out history of other causes of immunosuppression, such as use of steroids or cytotoxic drugs, and history of falling ill recurrently. These are histories that will point towards an immunocompromised patient. Now, more on our pneumonia. C, replace the C with P for pneumonia. So in pneumonia, you want to know the living condition of the patient. Is the room well ventilated? How many people live in the room? Is there exposure to biomass, such as smoke from burning of firewood, kerosene, or coal? So these are causes that will point towards pneumonia. So, and then finally H. H will be for cause from heart failure, cough from heart failure. Cough from heart failure, as I said, frothy sputum, history of leg swelling, history of easy fatigability, history of breathlessness. This will point towards cough that is caused from heart failure. So these will be associations that you ask when it comes to cough. There's going to be other videos that will discuss other symptoms and examinations. If you enjoyed this, do share with your classmates, and see you in the next video.